So today the topic is on the physiology of pregnancy, and specifically we are going to look at the systemic changes which occur in the woman when she is pregnant. Now, these are positive physiological changes which occur to help the mother accommodate and support the fetus throughout pregnancy. And so we are going to pick the various systems and see what occur in them. So starting with the cardiovascular system, during pregnancy, the cardiac output increases by 30 to 50%, and most of this increase occur during the first trimester, with the maximum increase being recorded between the 20th and the 24th week of gestation. And this increase is maintained until the woman delivers. Now, why must the cardiac output increase? It is necessary in order to ensure that there is a constant supply of oxygen and nutrients to the placenta, which supplies the fetus. Now, the increase in the cardiac output is first of all due to an increase in the stroke volume, whereas later in gestation, the increase is due to an increase or a rise in the heart rate. This is because getting to the end of the third trimester, the stroke volume decreases to near the pre-pregnancy state. And so the heart rate increases in order to maintain a constant cardiac output throughout pregnancy. Now, this cardiac output is even much more increased to about 15% in case of twin pregnancy as compared to a singleton. And we also find a significantly larger increase in the left atrial diameter, which is usually consistent with the volume overload. And so the plasma volume is increased by up to 50%, from around 2.5 liters to about 3.75 liters throughout pregnancy. And this is even much more increased in a multiple pregnancy, since there are more than one fetus, and also in a multigravid woman. Now, the stroke volume as well as the heart rate is increased. This is because we've already talked about the cardiac output being increased to about 50%. And the reason is cardiac output is the product of the stroke volume multiplied by the heart rate. And so if the cardiac output is increasing, then it means the products which comes together to give us a cardiac output may also increase. Now, the systemic vascular resistance decreases during pregnancy, and this results in a fall in the atrial blood pressure. Now, this decrease is most likely due to an elevated progesterone levels, which leads to smooth muscle relaxation. Also, we realize that the fall in the systemic vascular resistance rather allows blood to be shunted from other organs to much vital organs in pregnancy, such as the thyroid, the kidneys, and most importantly to the placenta, which supplies oxygen and nutrients to the fetus. Now, when we look at the blood pressure, we realize that there is a decrease in the systolic blood pressure of about 5 to 10 millimeters per mercury, and a decrease in the diastolic pressure of about 10 to 15 millimeters per mercury, which reaches a nadir at week 24. Now, between 24 weeks of gestation and term, the blood pressure slowly returns to pre-pregnancy levels, but it should never exceed them. So these are the changes which occur in the cardiovascular system, and they are necessary to contribute to the optimal development of the fetus, and also to protect the mother from the risk of delivery, such as hemorrhage. Now, still on the cardiovascular system, we realize that as the uterus expands, the diaphragm is pushed up and the heart is displaced upwards by about 4 centimeters, and also to the left, as you can see in this image. This is the heart of the non-pregnant woman, and because the diaphragm is being pushed upwards, we realize that the heart is also pushed up and also slightly to the left. We also realize that the anteroposterior as well as the transverse diameter of the chest wall increases, including the entire circumference of the thoracic cage. And so the heart sounds may be different from a non-pregnant state. And this is why you must adjust your stethoscope a little to the left anytime you are assessing the heart sounds of a pregnant woman. Also, in pregnancy, we realize that pregnancy is a high flow, low resistant state. And so the high flow may cause a murmur, which is usually a systolic ejection murmur, which is normal in pregnancy. However, anytime you hear a diastolic murmur, it isn't normal. And so it should require that further investigation should be performed. Preferably, we should undertake an echocardiography to rule out any abnormality in the heart. Now, during pregnancy, because of all these things that we've talked about, we also realize that hypotension and difficulty in breathing is seen in some women. And this is usually when they lie supine or when they lie at their back. And this is due to the fact that there is compression of the aorta and the vena cava by the growing uterus. And because of this, we need to encourage the pregnant women to lie on their left lateral side. Also, during cesarean section, the anesthetist must position the patient in the left lateral tilt to prevent hypotension. Now, in the respiratory system, we are going to look at it in terms of anatomical changes, pulmonary function, ventilation, as well as the changes which occur in the arterial blood gas. And so, anatomically, we realize that because of the hormonal changes which occur in pregnancy, there is mucosal edema of the airway. We also find, hypersecretion and increased mucosal friability. Then we realize that all of these changes are chiefly due to the effect of progesterone on the airway, causing, tissue edema. We also find capillary congestion and hyperplasia of the mucosal glands. And this is why it is recommended that a smaller ET tube be used in case the woman requires general anesthesia for cesarean section. Now, as I just explained, as the uterus expands, the diaphragm is pushed up and the anteroposterior and the transverse diameter of the chest wall increases, including its entire circumference. And so these changes causes a decrease in the pulmonary function, and specifically we are going to have a decrease in the functional residual capacity. Not that alone, we are also going to find a decrease in the expiratory reserve volume as well as a reduction in the residual volumes. Now, because of these, increase in the circumference of the thoracic cage, it allows the vital capacity to remain unchanged, and the total lung capacity, on the other hand, decreases only minimally by term. What about the ventilation in pregnancy? We realize that we are going to find, an increase in the minute ventilation, and this occurs in the beginning of the first, trimester, and it reaches to about 20 to 40% above the baseline by term. Now, the alveolar ventilation reaches, or increases by 50 to 70% during pregnancy. And this increase in ventilation occurs because of the increase in metabolic carbon dioxide production, and also because of the increased respiratory drive due to the high serum progesterone levels. Now we realize that the tidal volume also increases by 30 to 35%, and the respiratory rate either remains relatively constant or it increases slightly. Then also by the 36th to the 38th week of pregnancy, breathing improves in the woman, and this is usually due to lightening. However, we realize that when the presenting part engages or enters into the pelvic brim, it rather presses or compresses on the urinary bladder, and so whilst there is improved breathing around this time. There is also urgency and frequency of maturation around this time. Now, when we look at the arterial blood gas, there is going to be mild hypoxemia, which occur when especially the patient lies in the supine position. We also see that there is going to be what increased oxygen consumption at the beginning of the first trimester, and also this increase in oxygen demand increases by 20 to 33% by term, and this is because of fetal demands as well as increased maternal metabolic processes. There is going to be a decrease in the partial pressure of carbon dioxide to approximately 30 millimeters by the 20th week of gestation, from 40 millimeters during pregnancy. Now, this change leads to an increase in the carbon dioxide gradient between the mother and the fetus, and is likely caused by elevated progesterone level. This is important because there is a gradient that is created to facilitate oxygen delivery to the fetus, as well as the removal of carbon dioxide from the fetus. Then we also realize that during active labor there is hyperventilation as well as tachypnea, which is caused by pain and anxiety, and this may usually result in mild hypocapnia and respiratory alkalosis in the woman. Now, this image is depicting lung volumes in the pregnant state as well as non-pregnant state, and I'm sure you take your time to go through this to understand it much better. Now, with the hematological changes in pregnancy, we realize that even though the plasma volume increases by up to 50%, the WBC count or the WBC volume increases by only 20 to 30%. And so there is a misproportion over here, and this leads to a decrease in the hematocrit level. This causes what we call the dilutional anemia or the physiologic anemia of pregnancy. We also realize that there is an increase in the WBC count during pregnancy to a mean of about 10.5 million per mil, and this is usually caused by the effect of progesterone. Now, during labor, stress may also cause the WBC count to rise to over 20 million per mil. Now, there is also a slight decrease in the concentration of platelet, and this is probably secondary to the increase in the plasma volume, and also sometimes due to peripheral distraction. Now, although in about 7 to 8% of patients the platelet count may be between 100 and 150 million per mil, anytime there is a drop in platelet count below 100 million per mil over a short period of time, it's not normal, and so it should be investigated promptly, and this should be corrected, especially if the woman will require surgical intervention such as cesarean section. There is also elevation in the levels of fibrinogen and factors 7, 8, 9, and 10. However, the increase in coagulation has a protective effect in the sense that it is to help control bleeding in the postpartum period, although it increases the risk of thromboembolic events. And so we say that pregnancy is considered to be a hypercoagulable state with an increase in the number of thromboembolic events such as pulmonary embolism and deep vein thrombosis. The risk of these thromboembolic events is increased, especially in women who undergo cesarean section. Now, the increased rate in thromboembolic events in pregnancy may also be secondary to other elements of the child's triad, and so factors such as increased venous stasis, as well as damage to the vessel endothelium shouldn't be overlooked. Now, the actual clotting and the bleeding times do not change, in pregnancy. Now, in the gastrointestinal system, we realize that the stomach and the intestines are displaced by the growing uterus. As you can see over here, this is the stomach, this being the diaphragm, and see how the liver is pushed up over here. And look at the intestines, how it is compressed. And so the growing uterus pushes almost everything up, the abdomen. And so due to this mechanical and hormonal effects on the gastrointestinal system, all pregnant women are considered as a full stomach or to be in a full stomach state, even if they've not eaten for more than 12 hours. And because of this, it is recommended that a rapid sequence induction should be performed when the woman requires general anesthesia for cesarean section. Now, still on gastrointestinal system, we realize that nausea and vomiting occur in more than 70% of all pregnancies. And this has been termed morning sickness, even though it can occur anytime throughout the day. Now, these symptoms have been attributed to the elevation in estrogen, progesterone, and also increased levels of the human chorionic gonadotropin hormone. Now, they may also be due to hypoglycemia, and if it is due to hypoglycemia, we can treat it with frequent snacking. Now, the nausea and vomiting typically resolves by the 14th to the 16th week of gestation. However, it sometimes continues or even becomes worse off, and this is what we refer to as hyperemesis gravidarum, which is the severe form of nausea and vomiting, and it's associated with weight loss of more than 5% of the pregnancy weight, including ketosis. Now, in pregnancy also, we realize that the stomach has prolonged gastric emptying times, and also the gastroesophageal sphincter has a decrease in its tone. Now, when we put these two together, it leads to gastric reflux in the woman, including, sometimes tylism and also spitting in pregnancy. Then we also find that the large bowels also decreases its motility, and this decrease in motility leads to, increased water absorption, which further leads to constipation. And so when we put this together with the pressure of the growing uterus on the pelvic veins, then we may see things like hemorrhoids occurring in pregnancy. And those who already have existing hemorrhoids may get their hemorrhoids getting worse. Then the gallbladder's function decreases. We find that it gets dilated, and its emptying is decreased, and this leads to cholestasis, which may also result in an increasing tendency of gallstone formation in pregnancy. Now we realize that the serum albumin levels falls quite abruptly in early pregnancy. Then also we find that the serum alkaline phosphatase rise progressively and doubles the non-pregnant levels. Then finally we also see an increase in the serum cholesterol levels, which even gets doubled by the end of pregnancy. Now in the renal system, we realize that there is increase in the size of the kidney as well as dilatation of the ureters during pregnancy, and this usually leads to urinary tract infections as well as pyelonephritis in pregnancy. Now this UTI and pyelonephritis may also be due to the fact that progesterone slows down the motility of the ureters, and so urine stays in the tract for so long, and it serves as a receptacle for bacterial growth. Hence, the urinary tract infection. We also find that the rising uterus usually tilts to the right, and this causes compression to the right ureters, and this usually leads to hydronephrosis, usually after the second trimester of pregnancy. Now, when we look at the glomerular filtration rate in pregnancy, we realize that it increases by 50% in early pregnancy, and this is maintained until delivery. And as a result of this increase in GFR, the blood urea nitrogen as well as the creatinine levels decrease to about 25%. And this fall in creatinine is also due to hemodilution, which, if you remember, is as a result of the 30 to 50% plasma volume expansion when pregnancy commenced. Hence, anytime we find a serum creatinine level of about 1 milligram per deciliter in a pregnant woman, even though it may be normal in a non-pregnant state, this may reflect renal impairment in pregnancy. And so, due to this increase in glomerular filtration rate, we also sometimes find glucose in urine of the pregnant woman. And even though this may be a sign of gestational diabetes mellitus, it's usually physiologic. And so anytime we find it, we need to rule out other causes of gestational diabetes in the woman. We also have an increase in the renin-angiotensin system, which leads to an increase in the levels of aldosterone. And once we have increased aldosterone, we are going to have increased sodium reabsorption. However, these plasma levels of sodium do not increase because of the simultaneous increase in glomerular filtration rate. However, we are going to have increased water retention in the woman. Now, in the endocrine system, we are going to look at it in terms of the changes in the pituitary gland as well as the ovaries and placenta. Then we shall look at the thyroid gland and the adrenal gland. And so we realize that there is an increase in the size of the pituitary gland, and this is due to increased blood supply. And because of this, anytime there is excessive bleeding intrapartum or even postpartum, it may cause ischemia to the pituitary gland, and the condition that we call Sheehan's syndrome may occur in the woman. Now we realize that the prolactin levels increases by the 5th week of gestation, and this aid development of the mammary ducts and also help to establish breastfeeding. The prolactin also inhibits ovulation, and this explains the reason why breastfeeding mothers do not get their period. Now, the levels of the prolactin increases during pregnancy, but the levels decreases after delivery. But later on, when the baby begins to suckle, we get increasing levels of prolactin occurring once again. Now, the corticotropin releasing hormone from the hypothalamus stimulates the production of the mother's adrenocorticotropin hormone as well as cortisol. And the presence of adrenocorticotropin hormone and cortisol leads to the increase in maternal cortisol levels in the 3rd trimester. And this is very necessary for fetal lung maturation. And also, it leads to greater concentration of glucose available in maternal bloodstream for fetal consumption. Now, when we look at follicle stimulating hormone and luteinizing hormone, as well as even the thyroid stimulating hormone, we realize that their function rather even decreases because their role in pregnancy is quite limited. Now, the placenta produces the ACG, and this ACG doubles approximately every 48 hours during the early pregnancy, and it reaches its peak by the 10th to the 12th week of gestation and begin to decline to a steady state after the 15th week of gestation. Now, this HCG is the one which acts to maintain the corpus luteum in early pregnancy. And so we need the corpus luteum because it produces progesterone, and this progesterone maintains the endometrium during pregnancy. Now, eventually, the placenta develops and takes over the production of progesterone, and the corpus luteum eventually, degrades into the corpus albicans. And so the progesterone levels in pregnancy increases throughout the course of pregnancy. What about estrogen? The major estrogen in pregnancy is called the estriol, and it increases as well. And so we say pregnancy is a hyperestrogenic state. Now, the increased estrogen is primarily produced by the placenta, and we have very little coming from, the ovaries. Then we also have an increase in what we call the human placental lactogen. This is produced in the placenta, and the function of this is very simple. It ensures that there is a constant supply of nutrients to the fetus. Now, the human placenta lactogen, what it does is it breaks down fat to be used as another source of energy for the fetus. It also inhibits insulin. So as it inhibits insulin, it causes a diabetogenic effect in the mother. And this rather leads to increased levels of insulin and protein synthesis, as well as serum glucose for the fetus to use. So this is what happens in the ovaries and the placenta. Now, when we look at the thyroid gland, we realize that the thyroxine is essential for the fetus neural development. So the neural development of the fetus, is very essential, and so we need thyroxine levels to increase. But during pregnancy and the early stages of pregnancy, we realize that the fetal thyroid gland is not functional until the second trimester, and so increasing T3 and T4 levels in the mother ensures that there is a constant supply of thyroxine to the fetus in the early pregnancy. And so we also realize that estrogen stimulates the thyroid binding globulin to increase, and this leads to elevation in T3 and T4 in the mother. So that is the total T3 and T4 are elevated in the mother, but the free T3 and T4 remain relatively constant. And so overall, we say pregnancy is an euthyroid state, and this is because of the increase in the thyroid binding globulins. Now, in the adrenal gland, we find that there is increasing levels of cortisol, which I explained earlier on, and this is because there is increase in the levels of maternal adrenocorticotropin hormone, which causes the increase in the cortisol. We also find that there is going to be increase in aldosterone, and this is together with serum angiotensin 2. And so the increase in the serum angiotensin 2 and aldosterone levels contribute to sodium and water retention, which is required for the volume expansion in pregnancy. Then we also find that the corticosteroid binding globulin also increases. And so these are the changes which occur in the endocrine system. Now, in the musculoskeletal system and the skin, we find certain changes. Most of them are within the skin, and we find that there is what we call spider angiomata and palmar erythema. So this one being the spider angiomata is the dilatation of smaller blood vessels under the dermis, and this is the palmar erythema, and the erythema is prominent at the thana eminence. Then on the nipples and the umbilicus, we find certain changes. So we can see that the nipples become erect and enlarged, and also there is the appearance of the secondary areola with the Montgomery's tubercle. So these small nodules over here are the Montgomery's tubercle, and they are basically sebaceous glands. Now we also have some changes on the abdomen, which we call the linear nigra, which is the black line of pregnancy. It stretches from the symphysis pubis to the upper part of the abdomen, as you can see. Then we also have the striae gravidarum, which is also referred to as the stretch marks of pregnancy. And the linear nigra is as a result of increased deposition of melanocyte stimulating hormone. Then we also see as a result of the increased deposition of the melanocyte stimulating hormone, we get the hyperpigmentation in almost all over the body. And so when it's found on the face, sometimes on the cheek and also on the forehead and also on the nose, we call it the melasma or the chloasma. So these are the changes we find in the skin. Pregnancy is also associated with carpal tunnel syndrome, and this results from compression of the median nerve in pregnancy. But the symptoms are usually self-limiting. Also, the woman may complain of a shift in their posture, which is usually seen as a lower back pain. It, however, gets worsened as the pregnancy advances. Now, what about the metabolic changes in pregnancy? Now, we know that in pregnancy, the basal metabolic rate increases by 10 to 20%. Also, there is increase in water retention, partly due to the decreased plasma osmolality, as we've seen. And so, edema may sometimes be normal in pregnancy. However, when the edema is present with high blood pressure and proteinuria, your attention should be drawn to preeclampsia. Now, in pregnancy, protein metabolism is enhanced to supply substrates for maternal and fetal growth. We also see that fat metabolism increases, and this is evidenced by the elevation in all lipid fractions in the blood. Then also we see that carbohydrate has the most dramatic changes in pregnancy. So the levels of carbohydrate increases. Now, an important thing we need to know over here is that the optimal blood glucose in pregnancy is 4.4 and 5.5. So 4.4 millimole per liter to 5.5 millimole per liter. Now, whereas in a non-pregnant woman, signs of hypoglycemia begins when the glucose level is 2.2 millimole per liter. In the pregnant woman, a glucose level below 3.3 millimole per liter is considered hypoglycemia, and so we should pay attention to this. And so the diabetogenic effect of pregnancy is the normal physiological adaptation, which requires that there is a shift of the maternal energy source from carbohydrate to fat. And so the so-called diabetogenic effect of pregnancy is a normal physiological adaptation, which requires that there is a shift in maternal energy source from carbohydrate to fat. And so by using the fat stores which were laid down in the first trimester as the primary energy source, glucose is then spared for the growing fetus. And so as the nutritional demands of the fetus increases in the second trimester, together with, if you remember, we said there is insulin resistance, then fat storage decreases as it's mobilized to provide the mother with extra energy supplies. So this is some of the metabolic changes that happens in pregnancy. Now, the nutritional requirement increases during pregnancy and breastfeeding, and so an average woman requires about 2,000 to 2,500 kilocalories per day. In addition to the increased caloric requirements, there are increased nutritional requirements for both protein, iron, folate, calcium, and other vitamins and minerals in general. And so the protein requirement increases from 60 to 70 or 75 grams per day. And the recommended calcium intake is about 1.5 grams per day. Now, we realize that many patients develop iron deficiency anemia because of the increased demand on hematopoiesis, both for the mother and the fetus. And so, folate requirement increases from 0.4 to 0.8 milligram per day. And this is very, important in preventing neural tube defect. We, however, sometimes even recommend that even before the woman conceives, whilst the woman is planning to conceive, the woman can start taking, this folate or folic acid and continue with it throughout pregnancy. Now, all pregnant women are advised to take, prenatal vitamins during pregnancy, and these are designed to compensate for the increased nutritional demands in pregnancy, which may not be readily available in the food we eat. And so iron requirement increases due to the increase in red blood cell count. Furthermore, any patient whose hematocrit falls during pregnancy is advised to increase iron intake with oral supplementation. And this is because the most common cause of anemia in pregnancy is iron deficiency anemia, and so we must guard against that. Now, in terms of nutrition, I want to give a very simple advice on fasting. Now, it is not recommended for pregnant women to fast, skip meals, or even restrict carbohydrate intake. This is because maternal blood glucose levels are critically important for fetal well-being. And so prolonged fasting in pregnancy may lead to ketone production, which may be dangerous to the fetus. Now, although Muslim women are exempted from fasting whilst pregnant, those who wish to fast during Ramadan may do so under medical supervision if it occurs, especially in the second trimester. Now, fasting during the first and the third trimester are, however, not recommended. This is because of the possible dangers to the fetus from dehydration. Rather from malnutrition, it has got nothing to do with malnutrition. The danger to the fetus in these trimesters is dehydration. This is why it is not recommended that in the first and third trimesters of pregnancy, you shouldn't fast. Now, interestingly, fasting during Ramadan has been shown not to affect the mean birth weight of babies at any stage of pregnancy. And so mothers may report less fetal movement, during the day. But this is, compensated for by, increased activity at night as, the fetal diurnal cycle changes with that of the mother. And so the take home, from this slide is that we need to increase the nutritional requirement, especially the proteins, the calcium, the folate, and the iron. And we also need to guard against fasting. And if a Muslim woman wants to fast, then it is best done in the second trimester of pregnancy. So let's finish up with the changes in the breast and the reproductive tract. Now, as we've seen, there is a rise in estrogen levels, and this helps to stimulate the growth of the mammary duct, and also the progesterone levels increases to help cause alveolar hypertrophy, and so the two come together to prepare the breast for lactation. Then we realize that towards the end of pregnancy and also in the early preperium, the breast produces colostrum, which is the thick yellow secretions which is rich in immunoglobulins. And these yellow secretion is not just rich in immunoglobulins, it is also rich in antibodies and antioxidants, and it helps to build the newborn baby's immune system. And so within 2 to 4 days, it changes from colostrum to the breast milk. Now, with the vagina, we realize that there is, increase in the thickness of the vaginal epithelium, and this is because there is increased, blood supply to the area. Then also we have the cervix becoming swollen and softens, as we've seen. We talked about the signs of pregnancy, and so the cervix gets swollen and softens. And sometimes, because of the increased blood supply to the vagina and the cervix in pregnancy, in early pregnancy, the woman may experience spotting, some blood during sexual intercourse, which may be normal, not to cause any alarm. Then also, we also see in the uterus that in early pregnancy, the uterine growth is due to hyperplasia and hypertrophy from the activity of estrogen. Now, as pregnancy advances, the hyperplasia reduces, but the hypertrophy becomes very high. And so we get, changes in the weight of the uterus, not just the weight, the size also changes. And so we are going to have the weight of the uterus increasing from 60 grams prior to pregnancy to about 1,000 grams at term. And also, we realize that the endometrium of the uterus changes its name, and so after the embedding of the blastocyst, there is the thickening and increased vascularity of the inner layer of the of the endometrium or of the uterus, and this is now called the decidua. Before pregnancy, it was endometrium, but in pregnancy, it becomes known as the decidua. And so decidualization is marked in the fundus and upper part of the uterus. Normally, that's the site for implantation. I think this is all that I have for you. Thank you very much for your attention. Bye bye.